Welcome to Dublin for the annual meeting of the Society of Academic Primary Care. The meeting this year is coordinated by Professor Tom Fahey and his team from the Department of General Practice at the Royal College of Surgeons in Ireland. Margaret Couple is a friend and colleague, and in fact comes from a neighbouring practice. She gave the opening keynote address on cardiovascular disease. Really fascinating. Margaret has a long track record in research in the benefits of cardiovascular risk factor reduction.
It's not all population. I think individual interventions need background community and population support. Important, I think, that the initiative comes from the community and the academics play a role in its evaluation to ensure that appropriate documentation is kept to be able to provide evidence of value later. It's also important, I think, that the GP gets involved and is a leader, but also a participant in the activities that are organised.
The Helen Lester lecture is one of the highlights of the SAPC conference. Helen was a wonderful researcher with a particular interest in mental health. It was entirely appropriate that Chris Dowrick gave this talk, a beautiful talk, beautifully crafted, reflective, thoughtful, and he focused on suffering and our interpretation of suffering in general practice. I caught Chris immediately after his talk. It was really interesting to hear his thoughts.
I'm talking about two central things in medicine in general and primary mental health care in particular, which we tend to forget in the middle of our busy lives. The first of which is about the importance of acknowledging suffering, and the second, the importance of offering hope. And I think as GPs, we often shy away from suffering, but if we give ourselves a bit of space, a bit of room and a bit of encouragement, we can turn towards it. And in terms of offering hope, actually acknowledging the suffering openly is the first step for offering hope. The second step is about being thoughtfully positive in the way we present or frame the problems and potential solutions. The third step is most certainly using the best available evidence, and primary care has done a very good job over the last 20 years in generating some excellent evidence about ways of improving primary mental health care. And then the fourth way, which for me is important but is speculative, is about changing the ways in which we think about patients rather than as passive mechanical victims of circumstance, but people who actually are active and have an opportunity to control and manage their lives. So that's the gist.
Matthias Egger, another of our plenary speakers, well known in the fields of epidemiology, spoke about bad science or bad behaviour and the reporting of medical research.
I think my message is that as long as there is this gap between what is good for science and good for patients and what is good for the careers of individual researchers, it will be very difficult to change the problem of publication bias, of citation bias, of multiple publication bias, of outcome reporting bias, or p-hacking, or of hypothesis changing according to the results. The problem is that researchers, to advance in their careers, they need many papers, as many as possible, and they need to get them into the good journals, so they need positive results, interesting results, novel results, whereas for science we need sound research with sound methods that is independent of the results.
Theo Verhage from Utrecht spoke about patient safety and infectious diseases.
Risks in infectious diseases in the Western world are limited, but of course the risk can be serious. Yeah? So the problem is how to diagnose these not very frequent but serious complications, and that is a problem because evidence until now don't help us that much. And so we have to accept diagnostic uncertainty. About treatment, I think giving a lot of antibiotics is not the right answer. We should be restrictive in antibiotic use and inform our patients well and monitor these patients. I think that's the main thing to avoid risks in infectious diseases. I think that's the main problem.
Let's talk now to some of our distinguished paper presenters, Jennifer Walker from Australia and Kamal Matani from
We
Oxford.
developed the tool because we have to find a way to have an effective intervention to change behaviour, but it also is a way to actually get a mathematical model that will actually give us a more precise risk so that then we can actually use it in an effective model.
And I'm just going to talk to you for a few minutes about the role of novel oral anticoagulants for patients with atrial fibrillation. So these are drugs like apixaban, dabigatran, rivaroxaban, which have come onto the market in the last few, probably decade, 2 years, a decade or so, and generally are proving to be non-inferior to warfarin, with several advantages. So, for example, they often don't need monitoring, but with some caution as well. So, for example, there are concerns in patients with chronic kidney disease, as well as short half-lives, which may make maybe a problem when patients forget to take their medication. So, one of the things that we're looking at is to explore this through a systematic review, which we've just completed and submitted to Cochrane. But beyond that, what we're looking to do is to explore them in detail through the clinical study reports that the manufacturer provide to the regulator, the European Medicines Agency.
And a final word from Bruce Arrell from New Zealand, who presented one of the posters.
So neurolinguistic programming, if you look up Wikipedia, it says it's a pseudoscience. So we conducted a high quality randomized control using the rapid phobia cure, and we found that numbers needed to treat of 6 against an active placebo, active control group, in terms of reducing people's fear of heights. My hairdresser can now stand on ladders.
A great meeting, great science, wonderful speakers, and a truly superb conference. Thank you for joining me on this brief video.